Good afternoon, students. So today we are going to learn about enteric fever, which is caused by Salmonella, typhi, and Salmonella paratyphi A, B, and C. The enteric fever is also known as typhoid fever as well as paratyphoid fever. The competencies for this theory class are M3.3, M3.4, M8.15. Learning objectives. At the end of this session, students will be able to understand what is the term enteric fever, which are the etiological agents responsible in causing enteric fever, typhoid fever, paratyphoid fever, pathogenesis and clinical manifestations of this enteric fever, how to perform laboratory diagnosis for enteric fever, treatment and prophylaxis of enteric fever, prevention and control measures to be taken for controlling and preventing typhoid fever, paratyphoid fever. We all know Salmonella species. They have a wide range of clinical illness, and there are 4 major syndromes having own diagnostic and therapeutic problems, and they are considered separately. Today we are going to learn about enteric fever, which are these 4 major syndromes caused by Salmonella species: enteric fever, gastroenteritis, academia with or without mesenteric infection, and asymptomatic carrier state. Enteric fever is potentially a fatal multisystem illness caused by Salmonella typhi, also known as typhoid fever, and Salmonella paratyphi A, B, and paratyphi C, known as paratyphoid fever. So, enteric fever, a syndrome which is an acute systemic illness characterized by fever, headache, and abdominal discomfort, classically produced by Salmonella typhi, referred as typhoid fever, Salmonella paratyphi A, Salmonella paratyphi B, Salmonella paratyphi C. They are also responsible for causing similar type of illness, but which is less severe clinical syndrome, referred as paratyphoid fever. For this organism, humans are the only reservoirs. These are only the natural reservoirs for this organism. Incubation period for this particular organism ranges from 1 to 10 days, maximum up to 14 days. More than 2 weeks. Up to 3 weeks. So we'll start with the pathogenesis. Infective days required for causing the infection 10⁻³ to 10⁻⁹ by an organism. A must. They should be ingested through contaminated food or water, because the route of transmission is by ingestion of contaminated food or water, which is having these organisms, and the number should be near about 10⁻⁵. So these organisms, once ingested along with the water or drink which is having these organisms, that is directly carried to the stomach, and this particular process is a relatively rapid process, and they evade the effect of gastric acid. Similarly, the administration of antacids or gastric resection reduces the infective dose. Bacteria with food particles, and bacteria which are along within food particles, they evade the action of stomach acids. Host factors. Which are the host factors we are going to discuss here, or you know, which is the humans are the natural host for this typhoid and paratyphoid fever caused by Salmonella. Age, as per a specific age, isolation rate for Salmonella, as for some other gut pathogens, are higher for children less than 1 year of the age than for any other age group. But higher age group and children both are more susceptible age groups for most of the infection, and that's why higher proportion of infections are investigated in these two age groups. Risk factors. These risk factors promote the transmission, and that includes conditions that decreases stomach acidity and intestinal integrity. So, how the infection is initiated. Once these organisms, Salmonella, they enter the lumen of intestine, they are able to tolerate the action of digestive bile, but at the same time, here they need to compete with the prevailing gut flora. Whatever gut flora is there, they have to compete with that to set up the infection at that particular place. Therefore, they have to adhere to the gut mucosa and multiply at that particular site. Certain serotypes of these Salmonella genus, that include Salmonella species Typhi. These Typhi, they have the ability to express type 1 fibri. These type 1 fibri are able to adhere to the alpha mannose containing molecules. These alpha mannose containing molecules, they are present in the microvilli of Indian mucosa. At the same time, Typhi and other species, they do have pathogenicity islands, and these pathogenicity islands, they have the ability to encode. What they have the ability, they can encode similar binding sites or receptor for the adhesions which are present inside the host cells. Means for the bacterial adhesions and receptors, bacterial adhesions are there and bacteria have certain receptors. These receptors require similar type of binding sites and receptor in the host cell, and these receptors and binding sites are prepared inside the host cell by these pathogenicity islands, and which is again responsible for the attachment to the host mucosa, and the attachment of host mucosa is followed by the degeneration of microvilli to form breaches in the cell membrane, and through which these salmonella they enter the intestinal epithelial cells. Certain strains of salmonella they can further multiply in these cells and macropatches of Peyer's patches. Some can penetrate into submucosa and pass to the local mesenteric lymph nodes. All the clinical manifestations of these particular infection caused by Salmonella, that including diarrhea, all these starts after the penetration by the Salmonella of the ileal wall. Certain strains of Salmonella type infection involves invasion of bloodstream and various organs. So let's see entry, how these enter through the epithelial cell, M cell. The lining epithelial cells or M cells, these are lining the intestinal mucosa. And Salmonella, they attach there, and that trigger a mechanism which is responsible for forming membrane ruffles on the cell membrane where the M cells are there. And these ruffles, they come out and reach to the organism. These organisms which are attached to the particular cell lining, the intestinal cell wall, and they form a particular large vesicle, these ruffles, and they take inside all the bacteria which are attached on this lining, and this is called as bacteria-mediated endocytosis or BME. And this bacteria-mediated endocytosis, it is mediated or it is processed by a specialized type 3 secretion system. Following the entry to this, the bacteria get entered, and following their entry, these organisms, they remain inside these vacuoles in the cytoplasm. Now, these organisms get engulfed, which are present inside the vacuoles. So they get inside, they enter into the macrophages. How they get into inside the macrophages? That these salmonella containing vacuoles which has the salmonella, they cross the epithelial layer and they try to reach to submucosa, where these vacuoles which are having the salmonella, they get phagocytosed by the macrophages present in the submucosa, present in this particular area. Okay, now starts the stage of Salmonella typhi, which are inside the vacuoles, and these vacuoles are now inside the macrophages. From here, the survival of Salmonella inside the macrophages start. So Salmonella typhi, they have the ability to produce certain changes, alterations in their surface, lipopolysaccharide in their surface. Here, the lipopolysaccharide, which is present in the cell wall of Salmonella typhi, and they have the ability they can change the structure of this lipopolysaccharide. So, because of this change, now they are not susceptible to the lysozymal enzymes of these macrophages. What was the first thing? That organism, they attach on the lining, M-cells lining, and where they forms the ruffles. The ruffles engulf these organisms, which is called as BME, and this BME is carried out, mediated by the type 3 secretion system. Now they produce the vacuole. Vacuole has the salmonella. Along with the vacuole, salmonella cross the epithelial layer and reach to the submucosa. Once they reach the submucosa, these vacuoles containing salmonella get engulfed by the macrophages. Now the salmonella which are in the vacuoles and the vacuole inside the macrophages. Now the salmonella, they to avoid, to prevent the action of lysozyme excreted by the macrophages to kill the salmonella, to break down the salmonella bacterial cells, they alter the surface NPS. They make the alteration, they change the lipopolysaccharide which is present in their cell wall. And because of this change in the lipopolysaccharide in their cell wall, these Salmonella typhi, they become resistant to the action of lysozymes, which are excreted by the macrophages to kill them. And here onwards starts the primary bacteria. Salmonella, which are inside the macrophages, they get sprayed via lymphatics. They get entered into the bloodstream. From this, there is starting of transient primary bacteria. Bacilli then disseminate through the reticuloendothelial system. They sprayed via lymphatics, and from lymphatics they can enter into the bloodstream, causing primary bacteremia, secondary bacteremia, occurs from seeded organs, which leads to the onset of clinical disease. Okay, so this is the pathogenesis of Salmonella. This is the diagrammatic representation of pathogenesis of typhoid fever. You can see here the Salmonella typhi. They attach on the M-cell lining, the M-cells lining of intestinal wall. You can see here the enterocytes which are lining the terminal ileum. These are the Peyer's patches. These are the resident macrophages. Organism get inside these M-cells. From there, they reach to the mesenteric lymph node. From mesenteric lymph node, they reach to bloodstream, causing primary bacteremia. From bloodstream, they reach to the various organs, disseminate to various organs like kidney, bone marrow, gallbladder, spleen, liver, and from there, they again reach to the bloodstream, causing secondary bacteremia. And then there is widespread dissemination of this organism to other organs. Onset of clinical manifestation of enteric fever. Onset is what? It is an interval between ingestion of the organism and onset of illness. Onset is the signs and symptoms, appearing of the signs and symptoms. It starts with that. And this onset depends upon what? Infecting dose, size of infecting dose, whether 10 raised to 3 are ingested, whether 10 raised to 2 are ingested, and then multiplied and will reach up to 10 raised to 9. That all depend upon this infecting dose, size of infecting dose. And onset depend upon that. Onset is usually incidence. It can range from 3 days to 50 days. And usually it is about 2 weeks time period to appear the signs and symptoms. The early symptoms are usually pain. That can be seen in most of the other diseases also, other infections also. Here in enteric fever, that early signs and symptoms can be dry cough, hepatitis, which is associated with anorexia. Okay, so these are the big complications, and these are not specific for that particular disease. Not particular for that particular, specific for that particular complication. So these are dry cough, then hepatitis, and which is associated with anorexia. That is acute hemorrhage from nostril, nasal cavity, or nasopharynx. And it is usually associated with anorexia. That means patient will not feel hungry. There is lack of or loss of appetite. It is again associated with emotional disturbance of the patient. A dull, continuous headache, abdominal tenderness, and discomfort are the uncommon and early signs and symptoms. At the same time, many of the patient they can do complain about constipation. Disease progression. In untreated cases, temperature shows state bladder rise over the first week of illness, remaining high for 7 to 10 days, and then falls, rises during third or fourth week. Physical signs include relative bradycardia, then which is at the height of fever. It is a slower heart rate than normal. Petomegaly, splenomegaly, spots, rash, which is about 2 to 4 millimeter in diameter, slightly raised, discrete, irregular, balancing, pink macule, most often found front chest. These are salmon color maculopapular rash on the chest, trunk, usually seen in 30% of patients. This can appear at the end of first week. They can appear in crops up to dozens at a time and fade suddenly within 3 to 4 days. There's no scar left behind. This is characteristic but not specific for enteric fever. In enteric fever, the relapse is seen in apparently recovered patient, about 5 to 10% of patients, or untreated cases, relapse can be seen, which is usually shorter, mild than initial illness, but can be severe and fatal also. severe intestinal hemorrhage and intestinal perforations, which is serious complications that can occur, and these serious complications can also occur at any stage of the illness. Other serious complications are gastrointestinal intestinal infection, usually seen third to fourth. Neurological manifestations rare, includes meningitis, cerebral ataxia, neuropsychiatric symptoms like muttering delirium or coma vigil, such as paranoid psychosis, hysteria, delirium, and aggressive behavior. So this is the pathogenesis, diagnostic representation of pathogenesis of typhoid fever. First, Salmonella typhi get ingested, they reach to the GI, they reach to the centric lymph node. From there, the completion of the incubation period, which is 14 days, they reach to the blood. From blood, they reach to reticuloendothelial system, and from here, there is arise in the start of signs and symptoms of enteric fever, that is fever, nausea, abdominal diarrhea, and from reticuloendothelial system, organism proceeded to various other organs, liver, spleen, gallbladder, they reach to the Peyer's patches, and from there, again, they reach to the blood, causing generalized infection, and at the same time, they are excreted through the feces, the environment. Epidemiology. Host, humans are the only natural host for typhoid organism, that is Salmonella. Transmission is oral by ingestion or drinking of contaminated food and water. As per WHO, estimated prevalence is about 10 to 21 million cases with 1.2 to 1.6 lakhs deaths annually worldwide, and compared to of Salmonella typhi, typhoid fever compared to the paratyphoid fever, which has 6 million cases and about 54,000 deaths annually. Indian bears major burden of the particular disease with more than 6 million cases annually. The incidence can vary between countries, and depending upon that, it has been ranging highest, moderate, and low. Highest has more than 100 cases per lakh population per year. This can be seen in South Central and Southeast Asia. Moderate have 10 to 100 cases per lakh patient population. This can be seen in rest of Asia, Africa, Latin America. Low, less than 10 cases per lakh population, seen in rest of the world. Locality and age. Enteric fever is more common in urban area than in rural area, more common in young age children than in adolescent, and in adolescents than in adults. Factors which are favoring the transmission includes poor sanitation, improper cleaning of drinking water, contaminated water, food and drinks, lack of hand hygiene, toilet access, and another one is evidence of prior Helicobacter pylori infection. Salmonella typhi versus paratyphi. Salmonella typhi infection is more common than Salmonella paratyphi A. The ratio is 4:1. However, Salmonella paratyphi A appears to be increased in India due to increased vaccination against Salmonella paratyphi. Carriers. Untreated patient, they can convert into carrier and excrete Salmonella paratyphi in feces and urine. They know the feces and urine. They know types of carriers: fecal carrier, urinary carrier. Fecal carrier have bacilli which multiply in their gallbladder and excreted through feces, and these are commonest one. Urinary carriers have bacilli. They multiply in kidneys and are excreted through urine, and these are rare carriers. Duration of shield that the carriers continue to shape the bacilli feces and urine for 3 months, up to 3 months. This can be seen in 10% of untreated cases, and these type of carriers are known as temporary. Chronic carriers can shape the organism through urine and stool for more than 1 year and seen in 2 to 5% of cases. Okay. So chronic carriers can be seen in 2 to 4% of infected patients, which is more common. Usually female infant and old age people are converted into chronic carriers. Those which are having biliary tract abnormalities, and these biliary tract abnormalities which can lead to increased fecal exhalation. Abnormalities of urinary tract and associated with schistosoma hematobial infection of the bladder can lead to increased urinary excretion levels. Food handlers and cook, which are converted to chronic carrier, are very dangerous. They can excrete bacilli for many years. The best known example is Mary Alon, typhoid Mary, in New York-based cook, gave rise to more than 1,300 cases during her lifetime, causing several outbreaks. This is a picture of typhoid Mary, along with her bacteriologist, Ina Sharma. She was quarantined North Brother Island. She died over there. We will see the bacteriology. It is the most important member. Genus Salmonella, responsible for causing the fatal disease typhoid. Ebert first observed this typhoid bacillus in mesenteric lymph node and spleen in fatal cases of typhoid fever. Gafke successfully isolated in 1884 in France. Then Ebert cavity bacillus or Eberthiella typhi. Then in 1885, Salmon and Smith isolated American cholera bacillus called Salmonella cholera suis. Therefore, the name was given after the first author, the term Salmonella. So, this genus includes gram-negative motile organism having peritropate flagella. They parasitize the intestine of vertebrate animals, causing enteric fever, gastroenteritis, septicemia with a bit of focal suppression and carrier stage. This picture shows gram-same appearance of Salmonella, which is gram-negative bacillus. Cultural characteristic: colonies on microbes are lactose-fermented pale colonies, enriched medium that has salmonella broth and tetrathionine broth. They can be enriched in this particular medium for 12 to 18 hours, and then can be subcultured on selective media such as Macaulay agar, deoxycholate citrate agar, DCA, Salmonella shigella agar, and Centrea agar. Colonies on Macaulay agar and DCA are 2 to 3 millimeter circular stool and colorless pale color colonies. On Wilson blade, they produce shaped black color colonies due to production of hydrogen sulfide by the Salmonella typhi as well as Salmonella paratyphi B, except Salmonella paratyphi A, which is not able to form H2S, and they produce green color colonies. TSI, there is H2S production seen in 30 with alkaline slant, reaction by Salmonella species. They can ferment glucose, maltose. They are thin-red test positive, citrate positive, and they can produce H2S. This is the Copeland-White classification or Copeland-White scheme of antigen classification. The classification within the genus is based on the presence of different somatic and flagellum H antigens, which can be detected by agglutination with the respective antisera, serogroups based on O antigen. Salmonella are initially classified into serogroups. Earlier, the serogroups were named as later E, B, C, so on. Hence, you can see here the numbers as well as the letters. Currently, there are up to 67 serogroups which contain group specific O antigen. For example, serogroup 2, formerly previously known as serogroup A, has group specific O antigen type 2. This is what is a Copeland classification scheme. Molecular classification is based on DNA hybridization studies. The genus Salmonella consists of two species, Salmonella enterica and Salmonella congori. Within the species Salmonella enterica, there are six subspecies, namely Enterica, Salami, Arizona, Tri-Arizona, Kochi, and Indica. Each subspecies further differentiated into groups based on presence of somatic O antigen, flagellar H antigen, as described in Copeland scheme. Most of the pathogenic typhoidal and non-typhoidal salmonella are placed into species Enterica, subspecies Enterica. The nomenclature is as Salmonella species Enterica, subspecies Enterica, serotype Salmonella typhi. Antigenic structure based on important antigen based in the cell wall of Salmonella. They are classified as somatic antigen, flagellar H antigen, surface-cellular antigen, VI antigen on the certain species. So difference between somatic O and flagellar H antigen is given here. O antigen is part of cell wall present in MBBS. H antigen, it is made up of protein, flagellin, and it provides or confers the motility of the organism. In Widal test, O antigen of Salmonella typhi is used. In Widal test, H antigen of Salmonella paratyphi E, B are used. Less immunogenic, O antigen is less immunogenic, H antigen is more immunogenic. Antibody against O antigen, they appear early and disappear early, indicating recent infection. Antibody against H antigen appears late, disappears late, indicate convalescent state. O antigen and O antibody, they get combined and form a particular compact granular chalky clump-like agglutination, which takes place very slowly, and the required temperature for this is 55 degrees Celsius. H antigen and antibody, when they react, they form large fluffy clumps. This agglutination is very rapid, and temperature range required is 37 degrees Celsius for this agglutination. Serogrouping of Salmonella based on O antigen and serogrouping are different to differentiate into serotypes based on H antigen. Surface antigen or VI antigen, what is a surface polysaccharide or capsular antigen, covering O antigen, named as believed to be related with virulence of organism, expressed on few serotypes, Salmonella typhi, paratyphi C. This is poorly immunogenic, and antibody titer is very low, not used for diagnosis, hence not employed in Widal test. This can be poorly immunogenic, so therefore not used in Widal test. The antibody against VI usually disappear early in convalescence. Phage typing of Salmonella typhi can be done using VI specific bacteriophages, and VI antigen can also be used for vaccination purpose. Laboratory diagnosis. Type of specimen to be collected depend upon duration of illness. The prepared specimen to be collected are first in the first week of illness, you can collect blood for culture, bone marrow for culture, urine and aspirate for culture. In second and third week of illness, serum for serology, Widal test. Third to fourth week of illness, urine and stool for culture. So, isolation of bacillus, you have to perform culture, demonstration of antibody, you have to perform serological test like Widal test, demonstration of circulating antigen, immunological, serological test, and other laboratory tests. This is the pattern of laboratory diagnosis of Enteric Fever. So, in first week, we can collect blood and culture it, and that can be given positivity rate up to 95%. Blood picture will show leukopenia with relative lymphocytosis. In second week, we perform blood culture. The positivity rate is up to 50%. But if you perform Widal test, again, titer shown by the antibody will be low. In third week, we perform blood culture. Again, it gives positivity up to 25%, 50%. Widal test will show 100% presence of antibody or significant titer will be detected. Fourth week, Widal test again 100%. Stool and urine culture, they can become positive up to 90%. Blood culture 10%. If you collect blood, feces, urine, bone marrow, bile, rose spots, they can be if you perform culture. This specimen can be used. Now let's talk about blood culture. Blood culture is an ideal method for diagnosis in first week of fever, which becomes positive in about 90% of cases. Thereafter, positivity declines to 71% in second, 60 in third, 25 fourth, respectively. Into 10 ml of blood is inoculated into 100 ml of bile product. It is incubated overnight at 37 degrees Celsius. Subcultured on MC in Bacteriology or DCA. Overnight incubated 37 degrees Celsius. Next day, receive the colonies will be non-lactose fermenting pale blood colonies on Bacteriology and DCA. These colonies are cane stain by ground stain. They will be ground negative bacilli. Then they will be tested motility. They will be motile, actively motile. Then they will be prepared in suspension and biochemical reactions are put, such as we've seen with the TSI, citrate, silverate, glucose fermentation test can be done. All these tests will come positive, and that will confirm the identification of the Salmonella. Again, it should be confirmed with agglutination with specific anti-serum. This specific anti-serum can be procured from National Salmonella Reference Center, which is located at Central Research Institute, Kasar. To take a note that Salmonella are not isolated in first subculture. They should do subculture every alternate day for next 10 days unless it is reported negative. If blood culture are positive in first week, the rate of positivity is 90%. We have already discussed it. The chances of following the positivity rate is due to treatment with chloramphenicol. Because of this treatment, chances that blood culture may rapidly decrease in their positivity. Next method is Castaneda's method. Why they require to enroll or employ this Castaneda's or biphasic method, because they have to subculture repeatedly for 10 days. So regularly you have to expose to that organism, regularly you have to prepare Bacteriology, DCA to subculture, and if it is not grown on that will be the best. And again, chances that when you open the blood culture bottle, that will produce all subculture contaminate original one, or it may infect person who is performing the test. So all these disadvantages are overcome in this Castaneda's method, which is a double medium containing bile broth, agastor, and the same bottle. You can see in the picture. For subculture, you just have to take the water in the bile broth, which is inoculated with the blood. It will run over the agastor and automatically subculture it. And again, you have to keep it in upright position. The advantages is that it eliminates the possibility of contamination during subculture. It ensures safety to the person who is performing the work, and it is cheap, economical compared to daily wastage of another medias. Clot culture, 5 ml of blood is collected, it is allowed to clot. The clot is broken, it's sterile plastron and inoculated into bile broth. Advantage of clot culture, higher rate of isolation as bactericide action of serum is eliminated. Serum becomes available for the Widal test, and this is the benefit of clot culture. Feces culture. Stool and urine culture. You should for the isolation of Salmonella and third and fourth week of fever. They remain positive even after antibiotic treatment. Stool and urine culture are also done for the detection of carriers. So urine culture seldom becomes positive. Some urine are shaded in urine infrequently. Urine is centrifuged and deposit is inoculated onto meconchalia. Stool culture is done similar method. Other specimens such as bone marrow, duodenal aspirates. Bone marrow culture is employed during first week of illness, shows positivity up to 90%. Duodenal aspirate is recommended during first week of illness. Both blood culture and bone marrow culture are negative. Combination of blood and bone marrow are intestinal secretion culture is the best method to get 90% positivity first week. The culture smear and motivated testing gram stain smear made from colonies reveals gram-negative, non-sporing, non-capsulated bacilli. They are motile with very intricate flagellum. Identification of these organisms from colonies are made either by automated identification systems such as Multidrug or Widal or by conventional biochemical test as described earlier, that you have to perform catalase test, oxidase test, which will come positive to locate in this. The enterobacterial oxidase will be negative. They will show Widal test negative, citrate test negative, MBBS test negative, DSI will show alkaline. But in acidic salt, gas will present production of H2S, which is not seen in Salmonella paratyphi. Multidrug can identify Salmonella up to genus level, however, the overlap differentiate between serotypes as they share the same ribosomal proteins. Demonstration of antibodies. The test for measurement of HNO antibodies for typhoid and paratyphoid bacilli in patient serum. Tubes used for Widal test are rare tube, Felix tubes. Rare tubes are narrow bottom tube, conical bottom for H agglutination. Felix tubes are short tube, round bottom, O agglutination for O agglutination. Serum in varying dilutions. Serum can be CEV diluted from 1:10, 20, 40, 80, 160 to 320. And these are taken in different tubes. And again, they are mixed with an equal volume of antigen of TO, that stands for Salmonella typhi, O antigen, TH, Salmonella typhi, H, flagellar antigen, AH, Salmonella typhi, Salmonella paratyphi A, flagellar antigen, PH, Salmonella paratyphi B, flagellar antigen. These four antigens are available, commercially prepared antigens are available. They are added to all the four tubes, dilution tubes, which are serially diluted at particular volume, equal volume. And then all these tubes are incubated in water bath at 37 degrees Celsius for overnight, or some others they recommend it should be incubated at 50 to 55 degrees Celsius for 2 hours in water bath, and then examined for agglutination. O antigen shows compact granular chalk powder. Agglutination with its specific antibody. H agglutination is loose, fluffy, cotton wool type of agglutination. Identification, significant stages of disease. Antibodies appear by the end of first week, rise steadily till 3 to 4 weeks, and afterwards decline gradually. Demonstration of a rising titer can be shown by testing paired serums, which will be more significant than reporting result on single or first sample. Significant levels of antibody titer for O is 1:100 or more, and for H is 1:200 or more. Significant titer is any titer is not significant endemic countries like India, due to prior exposure, people will always have some baseline antibodies. Higher titers are only significant. The cutoff varies from the place to place depending upon endemicity of the disease. So, integration that shows significant titer in most of the places in India is taken as H-agglutinin titer more than 200 and no agglutinin titer more than 100. Low titers should be ignored and considered as baseline titer in endemic areas. False positivity Widal test may occur. False positive Widal test may occur due to anamnestic reactions. Anamnestic responses. It refers to the transient rise in titer due to unrelated infections. For example, patient may suffer with malaria or dengue typhoid test. Widal test may come positive with significant titer. Bacterial antigen suspension are not free from MBBS. Person with inapparent infection, person with prior immunization with TAV vaccine. Yes. Salmonella, typhi, typhi A and typhi B. Antigens are there. Agencies. Next. For photolysin antibody titer can be demonstrated by testing paired sera at first week interval. Is more meaningful than single high titer. Rise in titer in immunistic responses are transient that usually falls after first week, whereas in true infection, the titer increased by fourfold after first week. False negative Widal can occur in early stage, first week of illness, 8th week after 14, care in carriers, patient or on antibiotic, and because of ozone phenomenon, where antibody is excess. This can be obviated by serial dilation of the serum. O-proteins can appear early and disappear early, indicating recent infection. H-proteins can appear late and disappear late, indicating convulsions. Other antibody detection tests that are typhi test, IDL-TX test, IgM dipsticks test, or assays. Demonstration of circulating antigen specific for typhoid bacillus is present in blood and urine of the patient in early stages. It is demonstrated by coagulation test. Staphylococcus aureus colon strain, which contains protein A, stabilized with formaldehyde and coated with Salmonella typhi antibodies, when 1% suspension of such a sensitized staphylococcal cells mixed on slide with serum from patient in first week of typhoid fever. The typhoid antigen present in serum combines with the antibody attached to staphylococcal cells, producing visible agglutination in 2 minutes. Advantage: test is rapid, sensitive, and specific. Gives positive first week of disease. Carrier can be diagnosed by fecal culture, eye culture. Urine carriers can be diagnosed by urine culture. Repeated urine cultures, demonstration of A antibodies, can collect the swabs from the serum and actually work up the viral count, identification of the organism through filter paper or medical culture methods. Prophylaxis. Before prophylaxis, monitoring methods are there. Several polymerase chain reactions based on test methods. Example, nested PCR are relatively available and they can detect and differentiate typhoid salmonella by targeting various genes such as Antigenic gene, YROP, and FLIC gene. Typhoid can be effectively controlled by general measures like improvement in sanitation and provision of protected water supply. Vaccination of travelers against typhoid, which is recommended. the dose is not, but does not remove the need for good hygiene. So, parental tap vaccine, which is it killed food cells, Salmonella typhi, Salmonella typhi A and B, is no longer used in significant because of significant side effects. Parental PI polysaccharide vaccine, composed of purified capsular polysaccharide antigen, which is derived from Salmonella typhi strain TY2. Dose, single dose of 25 microgram of PI antigen, 1 transkilodal subcutaneously. It offers protection up to 2 years, can be given after 2 years of age. PI antigen that elicits the T-independent and IgG antibody response that is not boosted by additional dose of vaccination. 2 new tempered vaccines are introduced. Typhoral, the oral one, has live attenuated vaccine containing stable strains of Salmonella typhi strain TY2, 1A, 1A, lacking enzyme UDP, galactose 4 epimerase. On ingestion, it initiates infection, but self-destructs 4 to 5 cell division and not inducing any illness. This is because of lack of galactose 4 epimerase enzyme. The vaccine is enterically coated capsule containing 10 to 9 viable lyophilized mutant bacilli. The course consists of 1 capsule orally an hour before meal with a glass of water on day 1, 3, and 5. No antibiotic should be taken during this particular period. Protective immunity starts after 7th day. Last dose lasts for 4 years. Booster is recommended after every 3 years for people residing in endemic areas and travelers proceeding to endemic areas. Drug resistance in typhoid and salmonella. Antimicrobial resistance in typhoid and salmonella is a global problem. Multidrug resistance, Salmonella typhi is defined as resistant to chloramphenicol and receiving 4 triazole. These antibiotics were used to treat enteric fever past. MTR strains emerged in 1989 in China and Southeast Asia, including India. Since then, they have disseminated widely. Chloroquine resistance. Emerged afterwards, after 1990. And now it is extensively used for extensively is there since last 3 decades. Chloramphenicol resistant strains of Salmonella typhi were reported from Mexico and Kerala, India in 1972. R factor confirms multiple drug resistance in Salmonella. MBBS Salmonella are known to cause septicemia, meningitis, pyogenic infection, particularly in humans. In other strains, nalidixic acid resistant strains are due to increased use of chloroquine to treat multidrug resistance in Salmonella. Reported since 1990. Because of this, the strains reduce susceptibility to ciprofloxacin have emerged in India. Another reason, resistance to ceftriaxone. It has been reported recently. Both ESBL and AMC producing Salmonella typhi have been detected. Old is gold, meaning strains revert to susceptibility to amoxicillin, chloramphenicol, or triazole as well, not for long. The treatment for enteric fever, drug of choice, and alternative available. Empirical treatment. This is given before, which includes ceftriaxone 1 to 2 times per day for 7 to 15 days. Alternative, azithromycin 1 gram per day, oral for 5 days. Fully susceptible to all drugs, except fluoxetine Antigenic twice a day, oral 5 to 7 days. Now, given is ampicillin chloramphenicol, potranozole, multidrug resistance, simple processing. Now, ceftriaxone, azithromycin, allylic acid resistance has been treated with ceftriaxone. Now, azithromycin, simple processing, 750 mg twice a day, oral for 10 to 14 days. Carriers were treated with ampicillin or amoxicillin, probenzate, benzene for 6 weeks. Now it's treated with potranozole and ciprofloxacin. So this is all for Salmonella, typhi, and typhoid fever and paratyphoid fever, also known as enteric fever. They are the expected questions.